Hi, in today's lecture, we're going to cover bipolar II disorder and everything you need to know for a didactic EOR or PANCE exam. By the way, this is a video number 2. In the first video, I covered bipolar I disorder, and I plan to go down the list for blueprint for EOR and cover every subject from the psych in order to help you pass your exam. So let's begin with a question. So the question is, 32-year-old male with a bipolar II disorder presents with a severe depression. Which medication best targets this phase and prevents relapse? Lamotrigine, valproate, sertraline, or lithium? And if you don't know the answer to this question, don't worry about it. By the end of this lecture, we'll cover everything you need to know about bipolar II disorder so you never get these types of questions wrong again. So let's begin by covering the description of bipolar II disorder. So it is characterized by at least one hypomanic episode and one major depressive episode without any full manic episodes. And that is a key. These patients in bipolar II disorder will never have a full blown out mania. So hypomanic involves elevated or irritable mood, increased energy and activity, or another manic symptoms, but they will only last about 4 consecutive days and they will not be severe enough to cause the marked impairment or hospitalization. That is a key feature that separates it from bipolar I, as well as the time. So depressive episodes are often more frequent and disabling than hypomanic episodes. Bipolar II disorder typically begins in a late adolescence or in early adulthood. So the memory hook, I always advise my students to come up with a little stories, little shorts, whatever helps them memorize the information better. And what helped me is I would remember it as a bipolar 2. So bipolar 1 was, I know the 1 stands for 1 week, and the bipolar 2 is 2 moods. So you need 2 moods, 2 different types of moods, hypomania and depression, in order to qualify for bipolar 2. And there is no full mania. Bipolar 2, 2 moods, hypomania plus depression, no full mania. So exam tip, hypomania will last for about 4 days. There will be no psychosis and depression is prominent. So don't confuse with bipolar 1. They will have a full manic episode. Don't confuse this with a major depressive disorder. There's no hypomania or mania or cyclotimic disorder, which will be milder mood swings, but they're going to be lasting for over 2 years without major episodes. So what is bipolar 1 so we can differentiate that from bipolar 2? And a good mnemonic to remember the symptoms for bipolar 1 is dig fast. And they must have one manic episode with 3+ symptoms present. D stands for distraction, I for indestructibility, G for grandiosity, F for flight of ideas, A for activity increase, S for sleep deficit, and T, they're going to be very, very talkative. So in bipolar 1, you're going to see 3+ of these symptoms. They're going to be lasting greater than 7 days, and hypomania will be some of these symptoms, but they will only last about 4 days. What are the causes? Well, mostly they're going to be genetic. So they're going to have a strong family history, or there could be some influence from neurochemical imbalance involving dopamine, serotonin, or norepinephrine. Also, as in bipolar 1, the stressful life events can trigger mood episodes. So always for exam tip, family history is common, so ask about mood disorders in their relatives. And don't confuse this with substance-induced mood disorders. Check for substance use in their history as well. So if the questions then ask you about causes, you're going to be thinking genetic predisposition, neurochemical imbalance, or stressful events. Ask for about family history, and don't confuse this with substance-induced mood disorders. What is the presentation of bipolar II disorder and a physical exam? Well, they're going to present with a hypomanic episode. They're going to have that elevated mood, increased energy. They're going to be talkative. But all of that is going to be lasting about 4 days, not more like they would in a bipolar 1 when it's present for more than 7 days. And major depressive episode, they're going to have a low mood, anhedonia, fatigue, sleep disturbance, suicidal ideation. No severe functional impairment or psychosis during hypomania. And this is big because if they have any functional impairment, if they have psychosis, that would present as full mania and that would make them be a bipolar 1 patient, not a bipolar 2. So hypomania does not cause hospitalization or psychosis. Don't confuse this with bipolar I mania, which is going to last greater than 7 days and is going to cause marked impairment. And cyclothymic disorder, these symptoms are less severe and they're going to last greater than 2 years. So let's differentiate between mania and hypomania once again. In a mania, you're going to see duration greater than 7 days is going to require hospitalization. Severity can cause marked impairment or social occupational functioning. They may need to be hospitalized for that. They may actually present with delusions or hallucinations. Those are your psychotic features. And they're going to have that extremely increased energy. They're going to be irritable. They're going to be spending their money. They're going to be quitting their jobs impulsively. They're going to be spending money like crazy. And they may even believe they have superpowers. So all of those lasting greater than 7 days, marked impairment, may need hospitalization. That is mania. And a memory hack, mania equals major impact on life. So hypomania will last about 4 days, shorter and milder. Severity, there will be no marked impairment, can still function at work or home. Psychotic features are absent, and energy is elevated, irritable, but they are controlled. Others may think these persons are just overly confident or just very productive. So increased energy, they're talking more, staying up late, working, social charm. Exam tip, if function is preserved, you're dealing with hypomania. All right, so this video is sponsored by PA Study Buddies Psych EOR book, in which you will find every subject from the EOR blueprint covered in detail, just like this. Plus, as a bonus, you will find 120 mock interview or mock exam questions, just like the EOR, with detailed explanation of why the right answer is right, why the wrong are wrong, and everything else you need to study faster, save time, and score higher. So let's continue. Treatment. So the mood stabilizers are number one for treatment in bipolar II. Could be lithium, valproate, or lamotrigine if the depression is predominant symptom. Atypical antipsychotics, quetiapine, can be also used, and psychotherapies like cognitive behavior therapy could be adjunctive to the medications. Antidepressant use should be cautiously with mood stabilizers due to the risk of hypomania. So exam tips, focus on treating depression and preventing the mood switches. So the question is going to list several different medications, just like on our exam. Sample in the beginning of the lecture, and you're going to be focusing if they're telling you the patient is also depressive. Try to treat depression, try to pick lamotrigine over other medications because that will probably help them the most. Don't confuse this with antidepressant monotherapy without mood stabilizers. That is a one trick question and exam stem that they like to trip you on. All right, moving on. So complications. So something that test question can ask, what are the most common complications of bipolar II disorder? And that would be the risk of suicide, especially during the depressive phases. They can also have some functional impairment, relational occupational difficulties, but not likely, and medication side effects, as always, with all the medications we prescribe. So exam tip, monitor for mood changes and adherence closely. So let's summarize this with the high yield facts. Requires one hypomanic episode and one major depressive episode. Bipolar II, 2 stands for 2 different moods. Hypomania will last for 4 days. No psychosis or hospitalization. Lithium and lamotrigine effect for mood stabilization. Depression often predominant and disabling, and suicide is a major risk factor. So exam tip, you're looking for hypomania, symptoms lasting about 4 days, plus depression, you get yourself a bipolar II, there's no full mania. Back to our question, if the person presents with bipolar II disorder but with severe depression, you should pick lamotrigine as a treatment of choice. Valproate is better for acute mania. SSRIs can trigger hypomania, avoid it in monotherapy. Lithium is great for mania prevention, but is less effective in depression dominance. That brings us to the end of our lecture. I hope you liked this. Everything you saw here, you will see in the book. So go check it out, scan the QR code, and good luck on your exam. And I'll see you on the next test and next video.